So let me thank my younger brother Viraj for a kind invite. A very good topic. Actually, let me thank him again for giving me a topic, because that is something that I have prepared with conviction, and I hope everybody understand what the concept is all about. You keep on discussing in borderline resectable. These are resectable tumors, and I think doesn't make much of a change, and that I'll be telling you why. Now, why the concept of chemo or a neoadjuvant chemo has come in a resectable solid tumor? Remember your triple negative breast cancer or a muscle invasive bladder cancer. The concept is involved in those cancers where the overall prognosis is poor, because there are a high chance of micrometastasis. At the same time, there is a highly effective chemotherapy or the combination which is available to kill tumor cells. And here, pancreas. So if you look into a pancreatic disease overall, it is basically a systemic disease. How can I say this? So if you look into the long-term survival, it is only 10% with surgery. This means that 90% of the patients are micrometastasis on day one or become metastatic in due course of time. Now, when you look into the median survival, we call resectable pancreatic, but the survival is only 26 months. If you go to the recent ESCO presentation, hence we need more than surgery. So it could be an adjuvant or a neoadjuvant to improve overall survival. Now, my question comes, why now we should start discussing neoadjuvant chemo for all our resectable pancreatic patients, or in the other way, why should neoadjuvant chemo be a norm rather than an exception in all our resectable pancreatic patients? So now the times have changed. You cannot discuss the older data. Now we have effective chemotherapy combination. You remember my first three. So now we have a combination of FOLFIRINOX, which is a combination of irinotecan, oxali with 5-FU with or without leucovorin, and the equally effective nab-paclitaxel and gemcitabine, which gives you a respectable overall response rate, 30 to 40% with a good disease control rate, and only 15 to 20% progression. So in other words, helps in killing the micrometastatic, ultimately leading to overall survival. It is imperative that every patient should get this effective combination to improve the outcome. And when what we know is, my senior colleague or sir will debate that why not to give an adjuvant. But if you look into the standard trial in any of the studies, only 50 to 55% of the patients are able to take chemo post-op. So you are in other way denying your 45% patient which otherwise would have benefited and which would have led to improvement in overall survival. So the neoadjuvant chemo was, or we should give a neoadjuvant chemo because all patients get effective treatment. More importantly, those patients who progresses on chemo, I'll tell you an example of FOLFIRINOX. In the literature, 20% progresses. This may otherwise not do well. And if you look into the PRODEATE 24 in the adjuvant also, there was an early fall. These are the patients who would have unnecessarily done a surgery. So a resectable or a neoadjuvant help in tumor downstaging, which may not be so important, maybe in a body, in a head, but not in the body. There are less dose adjustment or a protocol violation when I give a neoadjuvant as compared to adjuvant. And more importantly, I can select my patient as good and bad depending upon the response. Added advantages in those where you are not sure whether it is resectable and borderline, you can still downstage your 30 to 40% of the patient. So is the data impressive? So the answer is yes. Now, if you look into the biggest study, neoadjuvant FOLFIRINOX meta-analysis that was done in 2019, what it suggests is these are impressive numbers. Resection rate is very good. In fact, better what we say in the Indian, in fact, in a very high R0, which is important, and an overall survival of around 2 years. Now, let me discuss the data. The biggest database till now, which has compared neoadjuvant versus upfront surgery, is from the National Cancer Database Registry, close to 15,000 patients, where you have 2,000 patients which were given neoadjuvant chemotherapy. Now, when you look into the analysis, there is a 28% improvement in OS. In fact, those patients who took adjuvant also, there was an improvement in overall survival in terms of 17%. So the biggest data till now has suggested that definitely an improvement in OS as compared to upfront surgery. Now, when you look into the subset analysis also, there was a patient with lesser T stages patient with lesser lymph node positivity, which was statistically significant. 48 versus 73, lesser positive marks in 17 versus 24, which was statistically significant. But what was more important was that the mortalities and the morbidities and the admission was not statistically significant. So what it suggests is this approach is a safe approach with a better OS. One more bigger meta-analysis which had included 38 studies. Please remember, what I am discussing is post-2015. The debate in 2010 with a single gem, that is not applicable. We are talking about more effective drugs now, and that is translating into survival. So 35 studies with neoadjuvant treatment. Now, this is important. What it suggested was a better R0 resection rate from 69% to 88%, from 14.48 months survival to 18.8. So what studies have suggested, or what the bigger data has suggested, is there is a definite consistent improvement in OS when you follow this approach. Now, a word or two about if you have a R0 resection, similar to what you see in breast, there is an improvement in OS. Do we have a data? So a landmark study presented by Italian Annals of Surgery suggested that yes, on a longer follow-up, if you can go toward the pathological CR, your survival is good. And the things that determine is probably the drug that you have used. So FOLFIRINOX, a negative node, and a pathological CR. So yes, now we are looking at what pathological CR with newer, which we never used to discuss. And that is why you should start thinking of our effective combination. A debate comes again that do I have a randomized data? So yes, the big or the main randomized data that has covered only resectable has been published by the Japanese, and you should see this was the recent data. So 2 cycles of GEM plus S1 followed by surgery. Somebody may say S1 is not there. It is more or less a 5FU and giving an adjuvant. So this was the main, what we say, a single study with a neoadjuvant. So a 10% improvement in 2 years, but more importantly, a 10 months improvement in OS when you give a neoadjuvant with surgery followed by an adjuvant, because you are able, so that is something that we have a phase 3 data, impressive, lesser lymph node metastasis, better. Now, which is the drug to use? So the drug that came in the trial that came in ESCO 2021 was a SWAP study. And what is suggested is, yes, you can use both your GEM-NACT PECLI as well as FOLFIRINOX. In fact, I am biased towards FOLFIRINOX, but the literature suggests that your R0 resection, lymph node negativity, DFS is more or less equal. More importantly, overall survival is equal. Now comes the most important thing. You say the OS is 2 years. And my senior sir will debate about adjuvant study, that is ProDH, which has a 5 to 4 month survival. Please understand, that is a thing that we don't understand. These are super fit patients. So patients who had undergone surgery were fit enough to undergo adjuvant chemo. There it was 54. So what was the denominator? There is no denominator here. Super fit patient, you give operate and you give adjuvant, that will definitely have it. So the main argument in neoadjuvant is you have all comers, good and bad risk. And you remember only 75% in Canadian undergone most operative adjuvant. But the most important thing is the ALIGN study, which has been going on, which is compared pre-FOLFIRINOX with surgery followed by post-FOLFIRINOX. Only 70% of the patient had undergone resection. More or less, only 55% of the healthy enough to give post-operative. So you are discussing this super fit population. So you cannot compare your adjuvant data with the neoadjuvant, which are all comers with intent to treat. So you cannot compare those data. You have to be sure that what is the best approach to give you a OS. A pilot study done now, which was done with FOLFIRINOX, so that definitely, look, please understand, the responses are better when you treat earlier. That is a dictum in all cancers, we know. So a ORR of 60%, pathological CR of 6%, and an OS of around nearly 3 years, which were all comers. So that is more important for us. Has NCCN guidelines mentioned it? So the answer is yes. The NCCN guidelines has mentioned either you can operate or you can give a neoadjuvant, but they have put a thing. So probably if you see these subset of patients, these are not as uncommon as thought of. So a resectable with a high CA19, a large tumor, large lymph node, excessive weight loss, excessive pain. These are absolute, I think, so indication where you should not think of a surgery at all, because probably they may have a micromet or they may not do well also. So all yes, but in these there has to be a particular thing or a particular favor of giving a neoadjuvant. What do guidelines say? Yes, Anatomical is important, but you should always look at biological and conditional, and 50% of the PEM may fall in these criteria, and you should always think of neoadjuvant, maybe in all, definitely in those high risk also. Two trials in future, which will be probably helping us to define this question, because my colleague may debate about the robustness of lot of data, maybe a obstructive jaundice where you want to do surgery, but those patients are also not fit enough. So you have a 15 jaundice, I don't think it is so easy to operate also. So these two studies, NORPEC study, a neoadjuvant surgery and an adjuvant, and NEO-NECT, probably there we have some data available where you give 2 cycles of NAP-PECLI gem followed by surgery, followed by 4 cycles. Probably they may help you in answering this question better. Early data looks promising. So if I have to summarize why I should use a neoadjuvant chemo even in a resectable pancreatic cancer is the best way to improve a survival in a very deadly disease like pancreas is to use all your weapons. So it is not only surgery, or you should have to use a chemo to improve your survival, being a systemic disease with effective chemo options. So that is what post 215, with the availability of a highly effective chemo combination, we need to make sure that all patients should receive chemo. And last but not the least is right treatment at the right time in a right patient should improve your overall survival. And I end my talk on this positive note. Act as if what you do makes a difference. And I think neoadjuvant chemo makes a difference in the outcome. It surely does. I thank you all for a patient here.
Thank you, Dr. Bharat. Thank you for the excellent talk. I'll call upon our next debater, Dr. Nilesh, doctor.
Can you upload the presentation from your side?
Sure.
I've emailed it to him.
Yeah.
Yeah. So first of all, thank you very much, Dr. Jagdish and Dr. Lavingia, for inviting me for this exciting meeting on GI oncology. Thank you very much, Dr. Bharat, for your excellent presentation. And I was actually of the same opinion till I went through the literature in the last couple of weeks after I accepted this presentation. And I'll try and convince you why I think this may be. Next slide, please. What I feel it may be a better approach for borderline resectable pancreatic ductal adenocarcinoma. Of course, I'm going to restrict our discussion to head cancer alone. And we'll start first by defining borderline resectable pancreatic ductal adenocarcinoma. Next slide, please. So there are various definitions, but the majority of the patients that we really would consider borderline resectable would be the ones with venous involvement, the ones with arterial involvement and superior mesenteric arterial involvement and common hepatic arterial involvement, though they are part of the NCCN and HPBA definitions. If there is occlusion of these vessels, it really classifies as locally advanced. So you must realize that these are only abutting the arteries. Only venous occlusion will classify as borderline resectable as per all the current definitions. So so next slide, please. I'll give you a few examples. So here, this is how it looks. Have a close look at this because it's important. In the diagram, it looks very fancy, but I'll show you later where this may not be that easy to determine preoperatively. So you can see a no tumor contact is considered resectable, abutment less than 180 degrees borderline resectable, and encasement more than 180 degrees, especially if the artery is unresectable. Next slide, please. So as Dr. Bharat has also pointed out, there are clinical variants, both biological and conditional, which subtype the borderline resectable groups. And it may be that adjuvant treatment is more beneficial in some form, either neoadjuvant or post-operative, for patients who are both conditional due to host-related diseases and biological with a higher CA19-9. Next slide, please. So these are some examples of, this is encasement where the entire vessel is occluded. Next slide, please. This is one where there is resectable. You can see the yellow arrow is pointing to the superior mesenteric vein, where there is a clear fat plane between the pancreas and the vein itself. Next slide, please. And this is where you have a borderline resectability, where you have abutment of the vein less than 180 degrees. Next slide, please. So why am I suggesting now that upfront surgery may be better in borderline resectable pancreatic cancer? So there is a lot of confusion as to what neoadjuvant therapy to use. Though Bharat has pointed out that in the last 5 years, there has been relative consolidation of treatment, there is still a fair number of non-responders to this treatment, and you may lose valuable time if your folfirinox gem, cap gemcitabine, or your nab-paclitaxel doesn't work, uh, and the non-responders can be quite high. You're in trouble. Also, remember very, very importantly that many patients who've got obstructive jaundice cannot take neoadjuvant therapy till they have had stenting, improvement in the liver functions, and a biopsy. So all these three are prerequisites for starting neoadjuvant therapy. As we all know, there are a lot of problems associated with US guided biopsy. A lot of patients, only about 30% come negative, falsely negative. Some patients, many patients suffer from cholangitis due to stenting, and you are unnecessarily going to stent patients who have got a bilirubin of 5 or 6, who could be readily available for upfront surgery. And some of these patients are actually lost to follow up and lost to surgery due to severe sepsis. I have a patient currently admitted who has got a large liver abscess in the attempt to stent and try and get a biopsy of the pancreatic ductal adenocarcinoma. And I don't know whether he'll ever come for surgery. His creatinine has gone up to 5, and he's a young chap, 45, with the pancreatic ductal adenocarcinoma, who is being considered for neoadjuvant treatment, and I don't think he'll ever come to treatment. So on the ground reality in India is that though this may be a very fancy new option, often it doesn't work on the ground. So it's very important to remember that in our attempt to try and push these patients to neoadjuvant therapy, you may actually fail them completely. Next slide, please. Now I'll show you some available data. So you can see this Dutch phase 3 pre-op trial. Just go to the next slide, please. So if you see what the primary endpoint was, next slide, please. So this was a trial comparing head-to-head neoadjuvant with upfront surgery. Next slide, please. And you can see here that there was not an overall very significant improvement in overall survival. And though he has earlier said that we are not using gemcitabine, these are all trials also. I am only putting which have been published after 2015. So this trial was published in 2018. Next slide, please. So there are still many people using gemcite. And if at all you use neoadjuvant, it is not something that you should consider using. People are not using it because there are severe toxic side effects of both folfirinox and nab-paclitaxel, and you can get into big trouble before you even reach the stage of resectability. Another article recently published, safety and efficacy of the preoperative or postoperative chemotherapy. Next slide, please. So this is a 3-arm design: surgery followed by gemcitabine, or upfront chemotherapy followed by surgery, and then adjuvant chemotherapy. Next slide, please. So here you can see that in all the 3 groups, there was a very similar pathological response and results. Overall response at 12 months, at 18 months was a very similar survival. So really there doesn't seem to be much to choose from when you come to this. So if you actually look at the number of patients who are treated with neoadjuvant and then go to surgery and complete the entire protocol, you may get a higher survival. But the number of patients who actually finish the entire treatment is much less than what we would desire. Next slide. Again, this is actually in 2018, the first head-to-head randomized trial published of neoadjuvant chemoradiation. So here there is upfront chemo plus radiation. So in this trial also, even though only gemcite was used, it's published just 2 or 3 years ago. Next slide, please. You can see the results that there is actually, though they found, so here is how you would look at the small print. They found, so this is actually a direct pickup from the conclusion from this annals paper. They found neoadjuvant treatment to be more effective than upfront surgery for BRPC with improved survival, followed by increased RC resection. There is actually no difference in recurrence patterns. So the recurrence rate was 88.2 in the neoadjuvant group and 88.9 in the upfront surgery group. So we all know that if you get a recurrence after pancreatic cancer, even though you got an R0 resection, the biology of the disease hasn't been changed. And this is the problem. In this group also, again, as I said, published as recently as 2018, there is no difference in actual recurrence rate. And finally, that determines what the patient's OS is going to be. Next slide. Again, the SPAC5 4-arm prospective multicenter study. Next slide, please. Comparing 4 different groups of patients. Resectable patients receive adjuvant therapy, and borderline resectable patients received neoadjuvant therapy. Next slide, please. Again, here you can see the secondary outcome, overall survival. Even though it was best in neoadjuvant treatment, the primary outcome was it was extremely difficult to recruit patients in this study, and they found that trial violations were present in almost 40% of patients. So many patients were crossed over to the intention to treat analysis, which was published elsewhere. It was found that there was actually no difference in either of the four groups. Next slide, please. Next slide. The last thing that I would like to mention is the technical innovation. So all these studies, you are now discounting the fact that there has been an improvement in technical results of patients who have been operated for borderline pancreatic cancer. So the results of borderline pancreatic cancer surgery in 2000 are very different from those in 2020. Just like there is a huge difference in the type of chemotherapy available for adjuvant treatment, it is important to also note that there has been a tremendous improvement in surgical techniques for borderline resectable pancreatic cancer, and a tremendous improvement in results, both with venous resection and arterial resection. So one of the important technical innovations started in 1993 and now rapidly adopted over most of the world, next slide please, is where you try to plan an R0 resection for BRPC. So this is something which is possible in majority of patients with BRPC, where you are able to, with an anterior approach, the MD Anderson has described it very well, where you transect the neck of the pancreas and take the SMV in your specimen right from the first step onwards. And you approach the artery anteriorly. You are able to then ligate the splenic vein and take the entire venous specimen, a part of the involved vein along with the specimen and reconstruct the vein with as good results as without venous reconstruction. So that's a huge advance in surgical technique where the number of R0 resections is the same as if you give neoadjuvant treatment. So this data will come just as the NAP paclitaxel data and the other data that Dr. Bharat mentioned will come on chemotherapy. The data on surgical technique and improvements in the results of doing R0 resection by the artery first approach or the MD Anderson approach will tell us that the number of R0 resections is as high. The problem of the R0 resection being less was not because there was a problem of the margin being positive. It was a change in the margin status, which was first described at the Leeds. And if you took the Leeds protocol now and established it in your department, you would be able to do all venous resections and be able to get an R0 resection in most patients with venous involvement. Next slide, please. So this shows the technique of doing a safe, SMA first approach where you completely resect the vein along with the specimen. Next slide, please. Next slide, please. Similarly with arterial resection, so if you have abutment of the artery, the results of arterial resection have dramatically improved in the last 10 years. Next slide, please. And you can see that the mortality has reduced dramatically even between 2010 to now, if you need to resect a portion of the artery. Next slide, please. Lastly, it's very important, this CONCO 7 trial telling us, next slide, please, that they actually tried to analyze between 5 different surgeons who would be able to diagnose and define BRPC. And next slide, please. You find that there is a tremendous variability even in diagnosis of BRPC. So what you are seeing as BRPC in large trials actually may be resectable pancreatic cancer. Actually, there is a lot of variability between both radiologists and surgeons in diagnosing BRPC. So this must be kept in mind when you are saying that, especially the person who is not very experienced will default give a neoadjuvant chemotherapy to these patients and not resect them. So I think that has to be kept in mind that there is a tremendous variability even amongst experienced surgeons. Next slide, please. Next slide, please. So next slide, please. I'll conclude now. Next slide, please. By saying that there is a variability in protocol of neoadjuvant treatment, better techniques to both tackle venous and arterial involvement to get R0 resections upfront, which seems to be the biggest reason for NACT, and at the moment, no confirmed improvement with NACT. Thank you very much for your patient hearing.
Thank you, Dr. Nilesh. Thank you so much. So for the expert comment, I would like to call Dr. Jagdish Kothari, sir. Dr. Kothari.
Yes. So at the outset, Viraj, the faculties which you have selected for this debate, outstanding. Both of them have talked about the science, and I think it was complete justification to the topic that is given to them. So Dr. Bharat has highlighted the advantages of neoadjuvant across the board, and he is strongly advocating that FOLFIRINOX, if at all we are able to give to all patients, then it would be beneficial in terms of R0 resection rate, which is improved. We are still not very much convinced that it has really made a big difference in the overall survival at this stage. So yes, there is a definite merit of improving the R0 resection. And even though we have touched upon borderline resectable in the discussion, but we are clearly talking about operable, upfront operable patients only. So now, as opposed to this, doctor has mentioned very clearly, and this is very important for the medical oncologist to know that results of the pancreatic surgery has improved in last 5 to 10 years significantly in terms of the better selection of patients with the better imaging, and so we would not accept straight away that about 50% of the patients may not be eligible for the adjuvant treatment. The time has changed, and that's where probably the definite advantage of the patients where they may not need probably any neoadjuvant treatment or adjuvant treatment also in some subgroup. So that's what we can definitely get. So in conclusion, I think both experts made a valid point that the time has come that every operable pancreatic cancer patient also should be discussed in multidisciplinary tumor board and decided whether this patient, on the merits of the fact that is available, because we have discussed about the real life scenario that you put a stent and patient having a cholangitis and may not come back to on the table at all. And all of us know that this is not just a theoretical point. This is what our day-to-day life. So that also we have to keep in mind that where are we treating this patient, under in which institution, and what are the other logistics which are possible for these patients, along with the surgeon you are talking about, or the chemotherapy setup which we are talking about, and that's where probably we have to take the decision. So I think this is what I would like to conclude from this talk. And anything, I mean, we may give a minute or two to Dr. Bharat and Nilesh also on this. Yes, Dr. Bharat.
I agree. So the only thing I am is that for resectable, we are not thinking about R0, R1. What is more is the biology of disease is bad in terms that there is a very high incidence of metastasis. The only way a surgeon can take care of local part, but still the outcome overall of you see is not good. So the only way to improve outcome is when we are able to give all our treatment. Surgery is the most important thing. Absolutely agreed, no confusion. But the main aim is that every patient should take chemo also, because that is the way we will try to kill those micrometastases. It may not be perfect. And now why we are increasingly discussing, and because now the options are more effective in terms of response rate. In older days, single agent 10%, less than 10%. And for the first time, we are talking in a pancreas a drug which give you 30 to 50% response. So probably the main thing is all patients should take all types of treatment. That is the only way. So what we said, multidisciplinary, probably the best way is Those who may progress, you may avoid unnecessary surgery, because that is why even the point against neoadjuvant was the patient may progress 20%. So they may otherwise also progress once you give it, because they are more or less micrometastatic only to start with, although we could not diagnose, and we may avoid it. So all carries a meaning. For me, the main strong point is micrometastasis killing, which is more important, more so in pancreas, which the biology is bad. That was the only thing I wanted to say.
Yeah, Dr. Nilesh, you have a last word now. You are on mute, sir.
Sorry, thank you. I think what you said, Dr. Jagdish, is very important. That each patient, we have to really work together with the medical oncologist, because both the treatments are extremely important for the patient. And as you very rightly said, that saying that only 50% of patients operated will go for adjuvant treatment today's world is not correct. I think majority of patients will be able to take adjuvant treatment. I think what Dr. Bharat said earlier is very important, that the biological status of the patient is extremely important. So I would definitely consider, if you have somebody who is got borderline resectable, but also has a high CA19-9, or has got back pain, or is lost a lot of weight, those patients, or is a very high bilirubin of say 25, those patients are ideally selected out for neoadjuvant treatment. And those patients who are upfront resectable, those who are young and who have a dilated duct and what we call a low FRS, fistula risk score, and are likely to make the surgery quite safely, those are the patients I would consider for upfront surgery and then for adjuvant chemotherapy. So I think together the medical oncologist and the surgeon can decide the suitability of that particular patient to go in for one or the other treatment. I think both are very important. Here we are only discussing whether which one should come first. So if this one surgery can come first in some patients, and neoadjuvant chemotherapy can come first in certain other patients, and I think together we can decide that for that individual patient.
Excellent, excellent, right.
Yeah.